So if we go back to think about really where ideas about immunisation start, I think we have to look back to the problem of smallpox, which was recognised in China in the 15th century as something that had the potential for control. So you have to understand that at this time, as a smallpox epidemic would go through villages in China, maybe half of the children would die during that epidemic. So incredibly high mortality. And so what was done, and I don't really know how the first time this was ever done happened, but they took some of the smallpox scabs and crushed them up and then insufflated them into the nostrils. They blew them into the nostrils of children who hadn't had smallpox, with the effect that it would immunise them, so that when they then met wild smallpox, when the next epidemic, they were protected. And this seems quite a bizarre thing someone to have thought of doing, and as I say, I don't know what the rationale was for it, but clearly they were immunising these children by putting some of the virus from smallpox scabs up into the noses of these children. And the problem with that is, of course, that the scabs contain some live virus as well as dead virus. So although many children were protected in this way, there was a mortality associated with using this technique, in that some of the children went on to get smallpox and die from it. But rather than half of them dying, it would have been down to less than 10%. So quite a big impact by doing that. But perhaps quite difficult to explain if it was understood that there was cause and effect of that process. So really from the 15th century, at least in some parts of the world, there was an active process going on to try and prevent this serious infection. And this whole concept didn't come to Europe until quite some time later. And here you can see in 1722, this lady Mary Montagu, brought a similar technique, except instead of blowing the scabs up the nose, what she was doing was she was taking the smallpox scabs and variolating them, which meant putting them on the arm of the child and then scratching them into the skin to immunise in that way. And this really had a pretty dramatic effect, and she did some testing first of all amongst prisoners and then amongst orphans in London to demonstrate amongst the orphans that the technique was safe. And presumably that indeed did happen, because this then became a very widespread technique across England. In London at that time, during the epidemics, it's well documented that 30% of people infected died from smallpox. But if you'd been variolated, the data that are available suggests it was only 1 to 2% of individuals died from the variolation. So an active process which led to a small number of deaths, but with a big reduction in mortality. And this process, although in England it only arrived in 1722, had been used across Africa, in India, and across the Ottoman Empire by about 1700. This, I think, really became extremely popular as a technique when the royal household were all variolated, and so then it certainly became widely used in England. So the real big change was this recognition by Edward Jenner that if you, instead of taking smallpox scabs, you took something from the lesions from cowpox, you could induce immunity in that way. And he made his observation because he'd become aware, being a rural doctor, that the milkmaids had very nice complexions. They didn't have marks on their face from where smallpox had caused scarring. And he made an association between the exposure that they had to cowpox, which is a very similar virus affecting cows, and they would develop cowpox lesions like the one you can see on the hand of Sarah Nelms, who was the milkmaid who actually provided the first cowpox virus, which was then used in Jenner's experiments. And so Edward Jenner took some of the lesion and variolated this boy, James Phipps, who was 8 years old. So exactly the same process as was been widely used in England with wild-type smallpox, but instead he used cowpox, scratched it into the skin of James Phipps. And then the next thing he did was try and infect him with smallpox to demonstrate that his new vaccine that he'd invented, which was the cowpox vaccine, was able to prevent infection. And James Phipps didn't get smallpox. And in fact, Jenner was so pleased with himself that he tried to infect him a further 8 times in order to demonstrate publicly that cowpox vaccine worked. Now, initially, people were not very impressed with the whole idea of cowpox vaccines, but eventually the treatise here was published, and following that, it became very widely used. And you can see that by 1825, about half of children living in the larger towns were being vaccinated with this cowpox vaccine, and variolation with smallpox became outlawed. And the smallpox vaccination industry, interestingly, became a mandatory vaccination here in the UK in 1853 for all infants. So we did have mandatory vaccination at one time, and really smallpox almost disappeared following that during the 1800s. Unfortunately, really by the next century, people were becoming increasingly resistant to the idea of a mandatory vaccine program, and so and also smallpox had largely disappeared. The fear of it had gone away, and so people were very much less willing to have their children vaccinated against it. Fortunately, in the mid 1800s, there was some changes in the law. Mandatory vaccination was removed, and somewhat counterintuitively, vaccination rates went up, and we ended up with a slightly different global strategy, which was recognizing every case of smallpox and then using vaccination to try and prevent any further cases. And finally, smallpox eliminated in 1971 in the UK and then globally in 1977. Interestingly, when you go back to what Edward Jenner wrote in his treatise there in 1796, he actually predicted that smallpox would be eradicated as a result of vaccination, and that indeed did happen. So that was what was thought to be the end game. And being in Oxford, it's worth mentioning that Oxford University did give Edward Jenner an honorary degree. He got an honorary MD, but actually that was for his work on finches rather than for his work on vaccination, so I'm a bit disappointed about that. There have been a few other scares around smallpox. In Birmingham, in 1978, there were 2 deaths following a laboratory accident where there was some research in a laboratory and 2 individuals became infected. And in 2004, some smallpox scabs were found in New Mexico inside a book on Civil War medicine, and so those were potentially infectious. So the smallpox, although has gone, there remains perhaps some risk in the future if some scabs are lying somewhere in a historical archive. And I think this is really important when we think about where we are today with polio, where we're very close to global eradication, but not quite there, to think about the timing of when we might stop with polio vaccination. So UK immunisation in the first half of the 20th century was a complete mess. The decisions about whether to immunise, what to immunise with and who to immunise were made locally, and there was no central coordination of that. Local health authorities did have to apply to what was then called the Ministry of Health to run immunisation schemes, but the programmatic decisions were entirely local. So this would be the local authority making all decisions about what to do. And diphtheria really is where immunisation starts as really important national programmes. And this was because it was recognised in the 1920s that diphtheria immunisation was really just being used for nurses, particularly nurses working in diphtheria wards. And in 1932, the Minister of Health suggested that really there needed to be a big effort. There were, at that point, 60,000 diphtheria cases and about 3,000 deaths in the 1930s. And so initially the ministry said we should encourage people to vaccinate children. Then things really moved on with a decision to try and eliminate diphtheria. And in 1940, all local health authorities were asked to introduce programs. And just 1 year later, if you think there was no national program at all, but within 1 year they had nearly 40% of children in schools vaccinated against diphtheria, which was a huge program. I guess it's almost like introducing a flu program for all children in schools. In 1959 was the first year in which there were no diphtheria deaths. So that's relatively recent. And this very encouraging poster was the approach that was being used to spearhead that program. And I think that really this was the thing that catalysed immunisation programmes, because the government saw that by centrally coordinating, they could have these enormous impacts on health. And the next thing that happened were the polio epidemics. And this was so dramatic in the 1950s that it was recognised by governments all over the world that they needed to intervene. And you'll be aware that there were both the injectable Salk vaccine and the oral Sabin vaccine were being developed. And really the 1947 epidemic catalysed this process both here and in the US to look at the introduction of polio vaccines. And so in 1955, a committee was formed called the Joint Committee on Polio Vaccine. And the plan was to advise on mass immunisation. So it wasn't initially thought of as a routine programme. And a year later, there was a plan put in place to start with a 2-dose vaccination programme for all children aged 2 to 9 years. And that was originally with the injectable vaccine, and then eventually by 1962, when the oral Sabin vaccine became available, that was recommended as the vaccine of choice. And you can see from the figure on the top right there that the introduction of that programme really stopped those epidemics and had a dramatic impact. And there were huge efforts to reassure the public about safety, lots of public figures being vaccinated to encourage things to move along rapidly. And this led to an understanding that immunisation really could transform public health. And there was a lobby which was interestingly led by both clinicians and the local health authorities of the Ministry of Health to say we need to do something much more coordinated. This shouldn't be left to local level. And that isn't usually what happens politically. Usually we all want to have power ourselves. We don't want to let the central government make those decisions. So it was an interesting point in where it was recognised in the peripheries that really central coordination was a good idea. And so there was a big set of meetings, the first in 1959 in May, chaired by Brigadier Sir John Boyd, in which experts got together to discuss how immunisation programmes might be put together. And they came up with 2 different schedules called P and Q, both of which were considered acceptable. I mean, it actually seems a bizarre decision, but I imagine there must have been lots of dissenting voices in the room. And the only way to get consensus was to recommend 2 different immunisation programmes rather than to do what would seem obvious, which would be to have one programme. So they ended up with 2 immunisation programmes. And these are the 2 programmes, P and Q. And in programme P, the DTP vaccine was given in the first 6 months of life, and then polio was given after that. Whereas in the Q vaccine, polio was the first vaccine that was given, and then DTP was given after that. And both of these were considered acceptable initially until 1968, when we moved to recommending just one schedule, which was Schedule P. So following those initial discussions, it was recognised that we really needed to have a committee that went beyond polio, that would oversee vaccine programmes. And I don't really think at that time there was a vision for the number of different immunisations that might be available nearly 50 years later. But they felt that just to manage and coordinate the programmes which were being introduced, a committee was needed. And so in 1963, the polio committee was replaced by the Joint Committee on Vaccination and Immunisation, which still functions today. And it is actually a blueprint for most of the national immunisation technical advisory groups which there are around the world, including the WHO committee called SAGE, which was set up in the late 90s. So JCVI has really been incredibly important in driving that oversight of immunisation in other countries. Currently, JCVI is an independent departmental expert committee that advises the UK health departments. And that's important because the advice is currently, with the devolved structure in the UK, is to the ministries in each of the devolved nations. So this is what the programme looked like 50 odd years ago, with smallpox vaccine being in the programme, but really it's not so dissimilar in the backbone of what's there from the programme that we still use today. Obviously there are changes in timing and so on, and there are a lot more antigens included today, but that's what the programme looked like in 1966. So JCVI has a very broad membership, and the reason for that is to try and have expertise both in the disease areas and from the different parts of public health and medicine and nursing that are required in order to make good scientific decisions about the immunisation programme, and importantly also includes lay members and good representation from people involved in vaccine delivery. And the terms of reference for JCVI are to advise the UK health departments on immunisations, taking into account evidence on the burden, vaccine safety, efficacy, impact and cost effectiveness of immunisation strategies. And the process of making decisions is listed here. So there's the potential for the Department of Health on JCVI's advice to commission various pieces of work, research on clinical trials, modelling work and operational analyses in order to inform those decisions which JCVI makes. And this really works well because there is a very strong capacity and ability to synthesise all of the different evidence that there is available from these different areas, and an expert secretariat who used to be based in the Department of Health but are now based in Public Health England, and who coordinate all of these activities. So in 2009 we had the first NHS constitution, and an absolutely critical part of that was introduced was the role of JCVI. And what was put in this is that if JCVI makes a recommendation, then the minister has to implement that. And so it makes the scientific advice from the committee incredibly powerful, and I'm not sure that any other country has that written in law where the scientific committee has that authority. In most countries, the similar committees to JCVI are advisory, and it is at the end of the day the minister's decision. Now, the only caveat that we have here in the UK, or at least in England, for this is that we can only make a recommendation if the minister asks us for one. And so they are sort of still in control. Here you can see just some selected immunisations which were introduced over the course of the last 50 years, bringing us up to 1998. And you can see that there was already some activity prior to the formation of JCVI with some use of BCG vaccine, tetanus vaccine, the polio program in place. But following the introduction of JCVI, there was a different type of oversight of the program and coordination, which brought us up through the 1990s. And this timeline of what's happened in immunisation has been put together by Sarah Lang, who many of you will know. I don't know if there's Sarah here today. Oh, you are, you're here. So Sarah has put this together after the most enormous amount of research to try and identify all of the original literature, including many hours in the British Library. So when we now look at the mid-90s, what did the immunisation programme look like then? Well, actually it looked pretty much like it did in 1966. And slightly simplified, we've got rid of smallpox, but it was essentially the same as in the 1960s when JCVI was first formed. And that doesn't mean to say that nothing was happening over that period. There were huge efforts to try to manage measles outbreaks, to carefully introduce mumps and rubella vaccination to avoid unintended consequences of those programs and to provide catch-up for those. As you can see on here, the introduction of the Hib vaccine, which was the second vaccine that had an impact on meningitis, mumps being the first one that was an important meningitis vaccine, and Hib being the first bacterial meningitis vaccine. Then from the 1990s, as many of those of you in the room who are sticking needles in babies will know, things have got a lot worse. So we have had the most enormous increase in both in the technology available, but in the potential for preventing these serious diseases. And over that period of time, we've more than doubled the number of vaccines that are administered through childhood. And here you can see some of those additional ones that were put in place. And here, just in the last decade, many changes that have happened, some of which are reducing numbers of doses, some of which are implementing new vaccines, and some are increasing the number of doses. And the whole reason why this has been happening is because of the recognition that started 50 years ago that we can have a huge impact on health in our population through immunisation. And you can see this consistent feature on these graphs of a big drop in the burden of disease for all of these different pathogens following the introduction of immunisation programs over that time. So this is what the immunisation schedule looks like today. And when you think this is now a change in the last 20 years from where we were 50 years ago, it is the most dramatic change. And what has happened with this is that we now have vaccines for almost all of the vaccine-preventable diseases, which we think are likely to have a substantial burden on hospitalisations and death in childhood. So that means that in some ways there isn't very much more to do that is likely to be population programs to hit those two things, to reduce mortality and to reduce hospitalisation. There are probably a few vaccines left that we will need to consider in the years ahead, and I'll come to those in a moment. But the impact of these programs is enormous, in that it's now quite difficult to think of what else you'd make a vaccine against for a population program that would have a big impact. And that's a pretty amazing position to be in 2019. And accompanying this has been a big change in under 5 mortality. And you can see in 1960, when all of this started, around about 26 children would die out of every 1,000, and now we're down to just a handful in the first 5 years of life. And that change isn't just through immunisation. There's, despite what you might read in the news, the general wealth of the population has increased very dramatically since 1960. And that means that children are better nourished, parents are better educated, and all of those things have an impact on the survival of children. There's no doubt that medicine has also moved on considerably, so our ability to manage and to treat patients has increased. But vaccination has played a part in this, and we have very good evidence of that from the surveillance programme led by Public Health England. So you all know very well that there are major challenges for our immunisation programme. We have problems with public confidence in immunisation, which have seen some falls in coverage, which that certainly confidence is part of the reason why coverage has fallen in the last few years, and Joe may touch on this later as well. I think we are fortunate in that there is still very strong political support from our governments over the last few decades for immunisation programmes. But that hasn't been the case everywhere, and there are certainly some countries in Europe where political parties have been trying to make their name on an anti-vaccine ticket, and the politicisation of immunisation I think is a real threat for programmes and for health, and I think it's a good news at the moment that doesn't seem to be an issue here in the UK. We also have this real challenge of when there are scare stories in actually generating evidence to prove that something isn't true. We have very good evidence about safety for all vaccines because of the way they're tested before they're used, but it's very difficult to disprove a spurious association which someone has suggested. And as a scientist, you usually want to try and test a hypothesis before standing up and saying, no, it's not true. And that makes it very difficult for most boffins to be able to deny the anti-vaccine things which come up, particularly when they're plausible. And I think that's been one of the difficulties that we have had as an immunisation community, is being bold enough and confident enough to dismiss the spurious claims that are made. I think it's going to be increasingly important, perhaps not here, but you never know, in changes in economic times, to make a strong case for immunisation programmes because they are expensive. This is, I say hopefully not here, but it is the case, particularly in middle-income countries who have no international donors helping support their immunisation programmes, and they have to make decisions about what to spend very limited resources on. And without good evidence, it's very difficult to know whether you should spend it on immunisation programmes. And of course, we are fortunate in having incredible surveillance for infectious disease in the UK. But that isn't true even across Europe, that governments are confident about the burden of disease they have and the worthiness of an immunisation programme. And so having good economic arguments based on surveillance data is very important. And we also, I think, in the changes in structures that you're all aware of in health systems, how difficult it can be to maintain strong systems that allow delivery of immunisation. So what about future priorities? And I think for the childhood programme, there are very few vaccines, as I've said, where we have a major impact on hospitalisation or mortality. So for RSV, the cause of bronchiolitis in infants, there are currently about 30,000 hospital admissions every year across England as a result of RSV. And if we did have a vaccine, probably administered in pregnancy or to the newborn, that could have a huge impact on hospitalisation. But from a global perspective, RSV is one of the top causes of death in the under ones. And so that really makes this an incredibly important target. We don't yet have an RSV vaccine anywhere in programmes, but there's a lot of research going on in that area. Secondly is Group B strep, which is a cause of neonatal meningitis, and this would be a vaccine administered in pregnancy, and is something which there is work going on in 3 companies at the moment which could lead to a vaccine. I don't think the technology is a problem. It's much more demonstrating to regulators that the vaccine is likely to work and therefore could be licensed. But I think most people in the scientific community don't think this is a technical hurdle. It should work. It's just you have to meet the regulatory standards. So both of those are things which could happen in the near future. You're going to hear a bit about varicella shortly, so you'll hear those arguments. I won't talk about it now. Perhaps the biggest challenge for immunisation is actually the elderly population, which is increasingly growing in numbers. And that means that the burdens on our health system of infectious diseases in the elderly becoming increasingly problematic. And the difficulty is that the elderly immune system doesn't make very good immune responses. And so most of the vaccines that we currently have in the elderly give relatively poor or short-lived protection. And that's true where it's the flu program or the shingles program or the pneumococcal program. They work, but they have relatively poor protection. And so I think understanding better how to make good immune response in the elderly, it will transform immunisation in that age group, and I suspect will be a major component of future research. There is, as I think was discussed last time, a new shingles vaccine, which we hope we will have in the UK at some point in the future, and that appears to work extremely well even in 90-year-olds. And so understanding exactly what it is about that vaccine which makes it work so well is going to be very important for planning future vaccines. And then beyond that, I think we really have lots of opportunity going forwards to develop new vaccines. There are many actually in development at the moment to target particular populations. So things like norovirus to deal with outbreaks of norovirus infection. And other nosocomial infections like C. diff and Staph aureus and resistant gram-negative bacteria, which are a real problem in various healthcare settings, and lots of research going on in that area. So that was all I was going to say today. I think we have made, and you have made through your efforts in sticking those needles in babies, the most enormous impact on on health in our population. But really, I think for all of us to remember that we're standing on the shoulders of absolute giants who had the courage to start immunisation programmes over the last century. That brings us to where we are today, where we have such an impact on health as a result of the efforts of prevention that we're all involved in. Thank you.